today for our second live webinar for HIV providers and care team members. We're still planning on a new one every 2 weeks, so the next one's going to be scheduled for August 19th. And then we hope to see you on another clinical person from your organization at the CHI meeting in San Diego, where the AETC NCHCMC will be hosting an almost day-long program on Sunday, August 28th from 9 a.m. till 2 p.m. I wanted to let you know that there's a question up on the clinical forum of the Virtual Learning Lab to ask for your feedback regarding what times of the day and days of the week would you prefer for these webinars. There's probably not going to be a time when we're all free, but we'd like to reach as many of you in real time as possible and at the same time being considerate of different time zones. Please check your Monday announcements and your webinar invitations for the specific time for any upcoming webinars. Today's discussion will contain some information about classification of HIV disease, opportunistic infection prophylaxis, and immunization practices. It sounds like a lot, and somebody says that's awfully ambitious for 30 minutes, and it is a lot of information, but we're going to go over it pretty succinctly, and the information that you'll need is readily available in a variety of easy-to-use formats to confirm specific details. Some of the information will really become second nature, but those pieces that we don't use very often, there are great pocket guides available and even a smartphone application that you can use on your clinic's computer or your smartphone. I want to take just a minute to review the CD4 cell count slide that we had a couple of weeks ago on the laboratory review webinar. The CD4 cell cells are actually a subset and a part of your total lymphocyte cells in your bloodstream. They're also known as CD4 lymphocytes, T4 cells, T helper cells, T4 helper cells, so all those things are synonymous. There is an absolute CD4 count that most people are familiar with and use that number. That number is the one that guides a lot of our practice in terms of prescribing prophylaxis, prescribing antiretrovirals, and so forth. 2 weeks ago in the webinar, I gave you one normal range, told you that the normal ranges could vary by laboratory, and the range that I gave you was 500 to 2,500 cells per cubic millimeter. In our HRSA clinical guide, they list the normal range as 500 to 1,300 cells per microliter. And we've had many discussions over the years, and a lot of us understand and know that millimeters cubed and microliters are not the same unit, don't mean the same thing, but for some reason it's still very, it's out there in the literature in both of these, using both of these units. So whichever unit you see, the range is the same. It can vary a little bit, but it's somewhere between 400 and 500 up to 1,300, 2,000, 2,500. So those are your actual normal ranges for your absolute CD4 cell count. The percent CD4 count is the percentage of CD4 divided by the percent is absolute CD4 divided by your total lymphocytes to give you a percentage. And this percentage is very stable over time and less affected by variations that go on in any individual's body from a day-to-day basis, such as somebody has a dental appointment and has just gotten some inflammation because they've had a good hygiene opportunity done with their teeth, or they had a vaccine and caused a transient inflammation in certain areas. So just to know that the numbers of your whole immune system vary a lot from day to day, but the percentage of CD4, since the CD4 is primarily and solely affected by HIV virus, should be more stable. I highlighted and bolded the last statement on this slide that tells you that anyone with a CD4 count of less than 200 cells per cubic millimeter or a CD4 percentage of less than 14 is diagnosed with AIDS. And that's, once a person has that diagnosis, they'll have it forever moving forward. Today's learning objectives, we hope to learn to apply the CDC staging system for staging and classifying HIV disease. There's also a World Health Organization classification system, but the one we're going to cover today from CDC is used most frequently in the United States. We're going to learn to use the CDC guidelines. The most recent ones were published in 2009 to manage the prophylaxis for both primary and secondary prevention of opportunistic infections. We're also going to apply and use the CDC guidelines that are for recommended adult immunizations to guide your immunizations required and recommended for your HIV patients. These guidelines were updated in February of this year and are not just for patients with HIV, but for all adults and adolescents in the United States. They just have a subnote section that will tell you some specifics about variations in many populations according to those specific vaccinations that are recommended. But we'll go over that a little bit later. Your primary reading for today and for this material is your HRSA Guide for HIV/AIDS Clinical Care, the big book that we gave you one copy of at the launch meeting, and hopefully by now you've ordered some additional copies for your clinical staff, pages 87 through 90 and pages 143 through 163. And again, I don't think you'll find this very tedious to go through. It's very well laid out and very succinctly and explained very, very well. We've got some additional resources listed at on the last couple of slides from the slide deck, and those references are for the guidelines and a few other excellent resources, and we have hyperlinks in the slide set that will take you to the actual document. I want to take a minute just to walk through this slide. This represents the CDC classification system for HIV infection. It is based on the lowest documented CD4 cell count and on any previously diagnosed HIV-related condition. The lowest documented CD4 is referred to as the nadir CD4, N-A-D-I-R, nadir CD4, and it's important to consider for some treatment decisions that we'll learn about later on.
At this time, we would like to ask people who are joining us if they may mute their lines so as to lower any background noise. Thank you so much. Doctor?
Thank you. I was just going to ask, is that my phone or somebody else's phone? I was trying to be real quiet over here. Thank you, Victor. This classification system is divided into CD4 cell categories in column 1 over on the far left-hand side, and clinical categories in A, B, and C in the next 3 columns. The 3 separate CD4 cell categories are Category 1 with CD4 counts greater than or equal to 500 cells per microliter. Category 2, I'm going to see if I can pull up my pointer. Category 2 with CD4 cell counts 200 to 499, and Category 3 with CD4 cell counts of less than 200 cells per microliter. Moving across the rows are the clinical categories A, B, and C. The A category is for asymptomatic conditions, which can include acute HIV, even though that's not particularly asymptomatic, as well as progressive generalized lymphadenopathy. Category B contains people are classified in this B category if they have certain symptomatic conditions, and we'll review a list of those in a few minutes. And those in Category C have the definition, have the diagnosis of an AIDS indicator condition, which you may also see listed or read or hear about as an AIDS-defining illness. An example, anyone with a CD4 count of less than 200 now and forever is going to have a diagnosis of AIDS. So on this entire bottom tier, the folks with a CD4 count of less than 200, whether they're asymptomatic, they'll be an A3. Whether they have a symptomatic condition in less than 200, they're a B3. And then all of the categories in this row, column, C1, C2, C3, will have an AIDS diagnosis. And that's contained here again as a summary in this particular area of the slide. Another couple examples using the slide. If a CD4 patient has a CD4 count of 425 and has one of the symptomatic conditions, then that patient would be classified as a B2. If the patient has a CD4 count of 600, so it'd be here, greater than 500, and has diagnosed with one of the AIDS-defining illnesses, such as a Burkitt's lymphoma, the patient will be classified as a C3, or I'm sorry, as a C1, because they have a high CD4 count, but they also have an AIDS-defining illness. Just to repeat and to reemphasize that any of the threes, A3, B3, C3, and C1 and C2 are all diagnosed with AIDS. If a patient's CD4 count is less than 200 or less than 14%, it's important to record this value and maintain that information in a prominent place in the patient's chart. A diagnosis of AIDS can impact later treatment decisions, even if the patient has a robust immune recovery, and an AIDS diagnosis also carries with it access to a different level of social and medical services. Category B symptomatic conditions are all based on two criteria. They are attributed to HIV infection or indicate a defect in the patient's cell-mediated immunity. They can also be considered to have a clinical course or a management piece that is complicated by the patient's HIV infection. In this slide, I've listed some examples of symptoms or conditions that fall under Category B. I have listed some of the most common ones, and the complete list is contained on pages 88 and 89 of the HRSA Clinical Guide. Some of the common examples are oral pharyngeal candidiasis or thrush, moderate or severe cervical dysplasia, oral hairy leukoplakia, and herpes zoster if you have 2 or more episodes in a year that cover at least one dermatome. The idiopathic thrombocytopenia purpura, I mentioned that a couple of weeks ago when we had our lab webinar, to say that sometimes people just, for no other identifiable etiology, will show up with an extremely low platelet count, and you end up diagnosing ITP, and you'll see pretty immediate improvement in the platelet count once that patient is started on HIV medications or the antiretroviral therapy. And peripheral neuropathy is also something that can go along with just an AIDS diagnosis, the presence of HIV, and we'll talk about its occurrence with certain ones of the older HIV meds in a few weeks. Some examples of AIDS indicator conditions. Again, this is a partial list, the entire list, and it's a very comprehensive and distinct list of diagnoses can be found on page 88 and 89 of our HRSA Clinical Guide. I'll just mention that bacterial pneumonia is not PCP pneumonia, but it's simple community-acquired pneumonia that a patient would have 2 or more episodes in 12 months, and that would be an AIDS-defining illness. Under the cervical carcinoma section, it says that diagnosis must be confirmed by biopsy. So when you see the biopsy report, you'll see it labeled as carcinoma in situ. So you'll know that that is different from any of the other low-grade, any of the other Bethesda staging systems for Pap smears. Under the lymphoma, there's a little bit of something that took me a long time to kind of keep straight. To be an AIDS-defining lymphoma, it has to be either Burkitt's, an immunoblastic form, or a primary CNS tumor. I wanted to point out that there is a pretty good frequency of non-Hodgkin's lymphoma and other B-cell lymphomas that occur in our patients regardless of their CD4 cell count. But I wanted to just emphasize that even though somebody may have a CD4 count of 600 and come down with non-Hodgkin's lymphoma, that is not an AIDS-defining illness. And of course, we know that PCP pneumonia is an AIDS-defining illness, which we'll discuss medicines to hopefully prevent that. And I wanted also to mention that in wasting syndrome, that there are specific criteria related to how much weight is lost over what specific period of time, and that criteria is found on page 89 of your HRSA-HAB clinical guide. Opportunistic infections are infections that are more frequent or more severe because of the immunosuppression in persons living with HIV. They are, generally speaking, caused by organisms that are ubiquitous in our environment but don't usually cause disease and pathology in young, healthy people. That was what was so unusual at the beginning of this epidemic in the early 80s, when otherwise young, healthy men were literally dying from pneumocystis pneumonia, a disease that was not supposed to occur unless an individual was very debilitated. You might think about older people who are generally in poor health, poorly nourished, and chronically ill with other diseases. In the early 1990s, we found that with appropriate immunizations plus chemoprophylaxis with specific medications targeted to specific opportunistic infections, that we had improved management of acute OIs as well as prevention of certain ones of the opportunistic infections. That all these measures together resulted in an improved survival, and did for many patients, we were able to, for many patients, able to prevent devastating opportunistic infections. The caveat to that whole statement is that we could only do that when the patients were in care and when we could manage them on a regular and routine basis. OIs, even despite all of the advances that we have and that we've seen in the last 20 years, continue to cause considerable morbidity and mortality. That said, many patients are unaware of their HIV infection and seek medical care only when an opportunistic infection becomes the initial indicator of their disease. Certain patients are aware of their HIV infection but do not take antiretroviral therapy because of psychosocial or economic factors. And another group of patients are prescribed antiretroviral therapy but fail to attain adequate virologic and immunologic response because of factors related to adherence, pharmacokinetics, or unexplained biologic factors. Though hospitalizations and deaths have decreased since the implementation of antiretroviral therapy and chemoprophylaxis, OIs remain a leading cause of morbidity and mortality in HIV-infected persons. I want to share a real-life scenario with you. One of your patients is diagnosed.
If I may, Doc, speaking of real-life scenarios, we do have a question from one of our participants who writes, if I may, I have a new 30-year-old patient with a CD4 of 641 or 29%, who had Zoster at diagnosis. Viral load genotype are pending. Do I classify him as B1 even though he has only had this one episode?
I'm sorry, what was he diagnosed with? Could you spell it for me?
Zoster. Herpes.
Right. But it was Zoster?
Yes, it was.
Okay. If we went back to this slide, we look at category B, and it's herpes zoster, which is shingles, and they need 2 or more episodes in an annual period, and at least covering 1 dermatome. So if the patient's just had 1 episode, then they're going to be classified, if their CD4 was 600 and some odd, it's going to be a B2. I'm sorry, a B1.
We've actually unmuted Lisa Cedarblum's line. Lisa, if you'd like to speak directly with Dr. Gilliam.
Sure, sorry, I just had to mute you. Yeah, I just was curious because he's actually my very first HIV patient, and I've only seen him once. He's really new to our practice. And I wasn't sure about the guidelines regarding how long I would wait to classify him. I mean, he's otherwise, young, 30, great great CD4 count, but presented with zoster. So I don't want to, you know, hold off on the classification for him, for his diagnosis form, et cetera.
Well, I think since you've got the CD4 count and that along with the fact that right now he is a B1, you can always change categories to get to a, if you will, sicker category. So if he had, you know, 2 episodes of zoster, I'm sorry, wait, I'm getting a little confused now. I think if it's just 1 episode of zoster that he's had, that's not going to put him anywhere except here.
Right, that's what I was thinking.
Yeah. And then, you know, when and if he has another one in this period of a year, then you could move him over to this category.
Okay, so fine to classify him as A1 and then see how he does throughout this year and change the classification at the 12-month mark?
Yeah.
Or sooner as needed. Okay, thank you. I appreciate that.
As I was trying to say on this, if people can always get to worse categories of 2 and 3, they can also move across this way. They just vary, even though that person, let's say, moved down to a B2 later on because his CD4 count dropped below 500. And because you had 2 episodes of zoster. He's not, if his CD4 count goes back up here, you're not going to move him back up to a B1. Once they get to a lower level, they stay at that lower level.
Okay, thank you.
You're welcome. Okay. All right. Okay. Okay. All right. I just wanted to mention in this slide that HRSA and HAB put a great deal of stock into retention and maintaining individuals into care. So when they look at us in terms of how well our work is, how well we keep patients in care and take good care of them, 2 of their core indicators are related to retention in care and appropriate management and monitoring of their CD4 cell count and their disease progression. So one of them is percent of HIV patients who had 2 or more medical visits that incorporate HIV care during your measurement year, and another one is the percentage of HIV patients who had 2 or more CD4 counts in that particular measurement year. Just moving along a little bit further to talk about how important prevention and prophylaxis is, another couple of their clinical core measures are designed specifically to look at effective prophylaxis against pneumocystis and effective prophylaxis against Mycobacterium avium complex. And we're going to talk about how to successfully manage those here in just a second. Primary and secondary prophylaxis. Primary, this is more definitional than anything else. Primary prophylaxis is the treatment given to HIV-infected individuals to prevent a first episode of an opportunistic infection, whereas secondary prevention, also called maintenance therapy, is given to patients to prevent a recurrence. So these are patients that have already had an episode of any of the opportunistic infections, but we will give them medications within certain parameters to prevent a recurrence. And we do have 3 opportunistic infections that are that we have appropriate prophylactic medication for, and those 3 are pneumocystis, Jirovecii pneumonia. That's what we so many years called pneumocystis carinii pneumonia, and it still goes by the name PCP instead of PJP. I asked that question not so long ago. And Mycobacterium avium complex, which we often shorten to call it MAC, and toxoplasmosis. Before we get too far into the nuts and bolts of prophylaxis with medications, let's step back just a minute and mention the most basic prevention messages, which are infections to avoid by avoiding contact or exposure to these potential pathogens. On pages 147 through 156 in your HRSA clinical guide, there's a selection of excellent information that can serve as a resource for patient education on first steps to help patients avoid getting sick. Wanted to let you know that we also added a few patient education resources in the collection of materials for today's webinar that you'll find in the Virtual Learning Lab. We don't have time to review all of these in our little short 30-minute webinar today, but please do read over them. There are some that we all know and teach every day, and some that we need to be refreshed on as they relate specifically to our HIV patients. This is a very abbreviated chart of the basics of OI primary prophylaxis. Column 1 gives the indication of when these prophylactic medications are needed, and it's primarily guided by CD4 cell counts. Column 2 lists the 3 diseases that I just mentioned that we do have effective prophylactic medications for. They're pneumocystis pneumonia, toxoplasmosis, and MAC, or Mycobacterium avian complex. Column 3 tells you the preferred regimen and in some cases gives you a secondary option. And column 4 tells you when it's safe to stop these medications. In the next, I'll just go over this. I think I have time to do that. For pneumocystis pneumonia, you will always want to start prophylaxis for that when their CD4 count, a patient's CD4 count is less than 200. This one has an has a couple of other caveats as well. So you could start prophylaxis for PCP if the patient has a history of thrush or they have a CD4 count of less than 14, which is our hallmark for AIDS diagnosis, or have any AIDS-defining illness. The agents used for prevention of PCP pneumonia are TMP, trimethoprim sulfamethoxazole, double strength, 1 tablet daily. It is also the same first choice prophylactic regimen to prevent toxo when the CD4 count is below 100. So you really don't have anything to worry about until a patient's, in terms of dosing, unless the patient is intolerant of the trimethoprim sulfamethoxazole because of a sulfa allergy or another reason, and then you would go to your second line regimen. We look at CD4 counts of less than 50 when we very strongly try to prevent the occurrence of MAC, and this is done with azithromycin, 2 600 milligram caps weekly. The next, I'll let you guys read that when to stop on your own, but I wanted to point out that a much more in-depth chart that has many more alternatives as patients are unable to tolerate first regimen, second regimen, and so forth, are contained in the table section of the actual CDC guidelines for opportunistic infections. And Jared has been kind enough to make PDF tables of each of these tables and put it in the resources section so that you don't have to download the entire guidelines if you don't feel like you need to. So that's table 1, the prophylaxis to prevent first episode, so that would be primary prophylaxis. The table 2 gives you indications not only how to treat an opportunistic infection, but also how to dose chronic maintenance for those patients that have had an opportunistic infection, but then you need to try to prevent a recurrence. Table 4 is giving you information on when to discontinue and when to restart, again, primarily based on changes in the CD4 cell count. This is an example of how to put all that information in a simple pocket guide. A lot of our regional AETCs do have pocket guides very similar to this. This one happens to be a little trifold group of charts and basic information that's very helpful. Some of the AETCs present you with some little small laminated cards. So if you find that something like this will be helpful, let us know, and we'll try to get you a copy of a very good one that you'll be able to use right at your desktop. I had some requests last week, and back for popular demand this week is going to be a case study. So I wanted to give you Mr. Johnson as a 26-year-old African-American heterosexual male, recently diagnosed with HIV at an STD clinic where he was also diagnosed with gonorrhea and chlamydia. His initial lab work, when we worked him up for his HIV, his CMP and CBC were normal. His repeat CD4 cell count was 120. I mentioned in our first webinar that we usually will run 2 CD4 cell counts before making any kind of treatment decisions, because we just want to make sure it's not some aberrant number or even, God help, a lab error. So we wouldn't want to start any kind of medications in long-term treatment unless we were, as sure as we could be that that was the actual CD4 cell count. Same thing goes sometimes for repeating viral loads. But this gentleman's viral load was 450,000 copies. So I'd like to ask you to think about, does he need prophylaxis, and what does he need to be prophylaxed for, and what would be your first choice for a prophylactic medication? And you guys can enter that into your chat format, and I'll be able to see what you write. I think that was just too easy because y'all are all getting it right. Okay, so what you would order, first, his CD4 count is under 200, but it's not as far down as 100. So within that 100 to 200 range, we need to prophylax against PCP pneumonia. The first choice for that is Bactrim double strength or Septra double strength, which are the trade names for trimethoprim sulfamethoxazole, and you'll have one of those given daily. Okay, and you'd always want to ask about, can you guys, somebody type in what you need to know about that particular drug in terms of allergies? Okay, somebody got it. It's sulfa. Sulfa allergy. Super. All right, we got that. Now, he calls the clinic after being on that medication, after being on his double-strength Bactrim for 3 days, and complains of an itchy rash all over. What are your thoughts about that? And then what do you want to do? I'm not going to try to flip back through those slides because that got me all confused a minute ago. So I'm going to let the people that downloaded the slides look back at your second option for what to use if somebody has and somebody's already typed it in, a sulfa allergy. So what would be your second choice for a medication to prophylax against PCP if somebody has a sulfa allergy? Y'all are quick. All right, the second one would be Dapsone, 100 milligram tablet daily, and most people tolerate that very well, even though there is a cross allergic pattern to Dapsone and sulfa. Still most people tolerate that very well. So good job, guys.
Doctor, we do have a question coming in from Mona Moore. Mona, we have unmuted your line if you'd like to ask your question. Mona?
Ms. Moore, did you have a question?
Well, we'll move on and return to Mona's question at a later time. Thank you, Doctor.
Perfect, perfect. Okay, we're going to move on quickly to immunizations. We're almost done here. In immunizations, you need to think about, why do I need to administer this vaccine? What specific vaccine do I need to administer? When? Who is a candidate for this vaccine? And who would not be a candidate for this vaccine? The big 4 vaccines for adults with HIV are an annual influenza vaccine, a pneumococcal vaccine, and you will probably still see some variations in the recommendations for timing. It used to be 1 dose every 5 years, and now it's a dose at diagnosis and then 1 dose again either at 5 or 10 years, and for a total of 2 doses in their lifetime. And keep your eyes posted for the headlines. It may change again. We just have to see how long that's going to last in folks. After you work up their hepatitis serology, if they do not have protection and protective antibodies against hepatitis A and hepatitis B, then you would go ahead and order those vaccine series. This next group of immunizations are recommendations for additional vaccines for consideration. The indications for each of these varies per individual, and the specific indication or contraindication, as well as other factors, are outlined in that new immunization guide from the CDC that came out in February 2011. There's probably as many pages of notes for exceptions and things to pay attention to on an individual basis as there are pages of the table. So I'm just going to refer you there. It's very straightforward, and all you have to do is follow those particular guidelines. Okay? In terms of a few caveats, I wanted to make sure that you heard us say that live vaccines are generally not administered to individuals with HIV infections. Occasionally, you have to weigh a risk-benefit ratio, and you might decide to go ahead and administer something, but as a general rule, you don't want to administer a live vaccine for somebody with HIV infection. An example of this would be people that come in and ask you for the flu mist, the nasal inhalation way to get your flu vaccine, and that one is a live attenuated virus, so you can explain to them that that one would not be okay for them to take. Vaccine administration, I've said this a couple of times, can also result in a transient increase in a patient's viral load. So if you happen to have labs scheduled a week or so after you're administering your number 2, Hep B or something, whatever you've got them coming back into clinic for, just maybe if you can, put off drawing that lab and looking at that HIV viral load shortly after a vaccine administration. I wanted to let you know that you're going to see some information out there, and here's some things in different webinars and such about the hepatitis B vaccine. There is some evidence to suggest that HIV patients need a double dose of the adult dosing amount for hepatitis B vaccine, and some people, even though it's not in the CDC recommendations, are doing that currently. A lot of the specialty HIV clinics are already doing that, but not all, and not a high overwhelming majority by any stretch of the imagination. But what that does is take away the opportunity of delivering the hepatitis A and hepatitis B vaccine in the combination Twinrix vaccine. So just if you hear that, just know that that debate is ongoing. And there continues to be a difference in opinion on when to vaccinate. Some people are very adamant that you should vaccinate immediately at the time of diagnosis for most of these vaccines. And another camp of people are just as adamant that those folks with very suppressed immune systems are unable to mount an antibody response, so they will wait and administer vaccines when the CD4 count gets to be 200 cells or higher. So you'll hear that in the hear and see that in the literature as well. I want to give this real quick as a homework case. So this is going to hopefully make our activities a little bit more interactive. The case and the answers to the question, along with the rationale and a discussion, will be posted by Monday morning. I'm going to give you the case here in just a second, and all that information is going to be on the clinical forum in the virtual learning lab. Please feel free to ask additional questions or post comments, or if y'all want to just add another question to the conversation, please feel free to do so, because that's what we're hoping to learn together in our learning community. Here's your case. It's Miss Butler. She is a 35-year-old Caucasian female. I forgot to put that on here. Sorry. She's a 35-year-old Caucasian female. Her CMP and CBC are normal. Her CD4 cell count is 85 cells, and that was repeated and verified. Her HIV viral load is currently 800,000 copies per ml. She's RPR negative, and that's her serology. She's toxo IgG positive. Her hepatitis A total antibody is positive. She's hep C positive. Her surface antigen for hepatitis B is negative. Her surface antibody for hepatitis B is negative, and her core antibody for hepatitis B is negative. So the question is, are there any other labs that you're interested in seeing? Does she need prophylaxis for any opportunistic infections, and if so, what would you prescribe? And I'd probably go ahead and say first and second. In case she doesn't tolerate first, if she needs something, what would you do for second? And then what vaccines would you recommend? And again, this is going to be posted, the case today and the answers on Monday. There's some additional reading and some additional slides that follow this one, as well as the resources or the references at the end, as well as some resources on the virtual learning lab. So I'm trying very hard to keep this as short as I can. I didn't make it quite to 30 minutes today as I look at my clock, so sorry. I will entertain any questions that anybody has right now. And thank you so much for your attention.
Thank you so much, Dr. Gilliam. We're now unmuting all phone lines if you'd like to ask a question of the doctor. Also, if you submit a chat question, we will read it aloud and for all participants to hear. Not hearing any questions, I'd like to thank you all for participating on today's web conference. A reminder that a recording of today's call will be available shortly on the Virtual Learning Lab's Building the Foundations page. While there, we invite you to ask follow-up questions by clicking on the Forum tab to participate in the HIV disease classification, by prophylaxis, and immunization discussion. You may also contact Dr. Gilliam or any member of our staff by emailing us at clinical@nchcmc.org. Thank you. Enjoy the rest of the day, and have a great weekend.
Bye, everybody.
Bye-bye. Bye.